Dear colleagues, it's a great honor to be here today and to give you a little insight in my PhD topic on predictive and prognostic biomarkers in urooncology. My name is Tamás Fazekas and I'm a PhD student and recently a urology specialist at the Department of Urology at the Semmelweis University. First of all, I have a vision. I strongly believe that with the development of precision medicine and individual molecular targeted therapy, the life expectancy and life quality of cancer patients can be highly improved. And in line with this vision, my personal mission is to find biomarkers which can guide optimal therapy sequencing in both prostate and bladder cancers. And in line with this vision and with this mission, we set up two specific goals in 2021. And in both projects, we are assessing the same patient population, the so-called BRCA or BRCA positive metastatic castration-resistant prostate cancer patients. So now let's move on with the first project. I've got really bad news for the boys here, that 1 out of 8 men will develop prostate cancer during their life. It's a huge number of patients, and 10% of the advanced cases are the so-called BRCA or the BRCA mutation-positive patients. Well, why is it important for us in prostate cancer? Because it leads to a much more aggressive disease, and these patients' survival is 50% worse compared to the mutation non-carriers. And beside the different biological attributes of these cancer entity, these patients represent a different clinical entity as well. In the treatment of advanced or metastatic mCRPC prostate cancer patients, we can choose in the first line from abiraterone, enzalutamide, docetaxel, and in the later lines between PARP inhibitors, PSMA ligand treatment, cabazitaxel, and platinum treatment. And these BRCA-positive patients are optimal candidates for the PARP inhibitor and platinum chemotherapy. But the question of which first-line available treatment is the best for these novel molecularly selected subgroup of patients is the best, we don't know. So the aim of the first project was to assess the treatment responses to first-line available treatments in BRCA-positive mCRPC patients. Well, this kind of aim would cry for an interventional type of meta-analysis, but during our preliminary search, we haven't found any articles which would have been comparing these agents to one another in this molecular subgroup of patients. So we ended up performing a descriptive meta-analysis with our questions assessing the so-called PSA 50 response rate, which is the PSA decrease at least 50% from the baseline level. And in our second question, to be a bit tricky, we set up an interventional question in which we were assessing the progression-free survival of these patients based on individual or estimated individual patient data. And using random effect Cox regression model, we tried to compare these agents to one another. So let's see the results. The PSA 50 response rates in the first treatment line, we could assess almost 100 patients. And in case of abiraterone, 52% responded. In case of enzalutamide, 64% responded. And for docetaxel, 55% responded. As you can see here, enzalutamide-treated patients tended to have the highest response rate. And in terms of progression-free survival, on the following Kaplan-Meier curves, you can see the raw data from the specific articles with the continuous line, the abiraterone-treated patients' survival, and with the dashed line, the enzalutamide-treated patients, you can see. And you can see a trend towards a better progression-free survival to enzalutamide. And in a random effect Cox regression model, we found a 53% lower risk for progression for the patients treated with enzalutamide. To sum up things, first of all, I would like to highlight that this is the first meta-analysis in this topic, providing a comprehensive overview with these outcomes in this novel patient subgroup of patients, and we could use individual or estimated individual patient data for our analysis. Of course, we have to highlight our limitations as well. First of all, as you could see, obviously the small sample size, and we couldn't find any studies which would have compared directly the agents to one another. There may be a bias based on the progression-free survival because it's a composite outcome, and the BRCA mutation test method may have differed among the studies, which may lead to, again, a possible bias and the limitation of our results. But what can we take home from all this? First of all, we have shown that BRCA-positive patients respond to all standard first-line treatments. However, we detected that enzalutamide treatment had the highest PSA 50 response rate, and a benefit in terms of progression-free survival. And it's particularly important for us for the everyday practice, because now we know that these patients respond to all standard first-line available treatments. However, we have to know that there may be differences between the agents. And our results are highlighting the need for molecular marker-driven interventional RCTs to compare these first-line available agents to one another, to have a higher level of evidence in this topic. And I'm really happy to tell you that this manuscript has been published in the 6th best urological journal in last December. So now let's move on with the second project, in which we are assessing the same patient population. And I have to tell you that despite the 7 different types of agents that we can administer during mCRPC, the 5-year survival of these patients is only 30%. So we definitely need markers to optimize our treatment outcomes. And therefore, in the second analysis, we were focusing on the later line available treatments. Again, the PARP inhibitors and platinum are on-label treatments for BRCA-positive mCRPC patients, while the cabazitaxel and PSMA ligand therapies are other novel, generally used agents in this population, in mCRPC. So our aim was assess the later lines here, and we set up the same clinical questions, as there are no trials comparing directly to one another these agents. In the first question, the PSA 50 response rate was assessed, and in the second, the progression-free and the overall survival was assessed based on individual patient data. So we started with more than 6,000 articles and ended up around 23. And let's see how results with the PSA 50 response rate. Here we could assess more than 700 patients. For PARP inhibitors, 69% responded. For platinum, 77% responded. And for cabazitaxel and PSMA ligand treatment, only 28 and 50% responded. And I would like to raise the attention only on the PARP inhibitor on-label agents, the PARP inhibitors, and to the platinum, that here we found no subgroup difference between the two agents, so these response rates were pretty much comparable to one another, which finding was shockingly, for us it was shocking that this was endorsed by the overall survival analysis, that our analysis did not show any difference between these two on-label agents. And moreover, I didn't tell it to you during the methods, but we wanted to assess somehow the different PARP inhibitor compounds like olaparib, rucaparib, talazoparib, and niraparib. We wanted to know that how similar are these to one another. So we performed a median pooling from the of the single arm curves from the big prospective trials of these agents. And we found a median progression-free survival of almost 10 months and the median overall survival of more than 17 months of these compounds with a low level of heterogeneity, which is telling us that these agents, despite their different pharmacokinetic and pharmacodynamic attributes, are pretty much comparable to one another in terms of these outcomes. So as a summary, I would like to highlight that this is the first meta-analysis in this topic. We could reach a large sample size with PARP inhibitors and platinum treatment. And again, we could use individual or estimated individual patient data for our analysis. Of course, we've got some pitfalls here as well. With PSMA ligand and cabazitaxel, our sample size, the literature is pretty much limited with these agents. And again, there are no studies comparing directly the agents, and we could include only prospective trials only in case of PARP inhibitors, so this is a serious limitation. But what can we conclude from all this? First of all, we have shown that BRCA-positive patients respond to later line on-label treatments like PARP inhibitor and platinum, and the PSA 50 response rate and overall survival with platinum was comparable to PARP inhibitors. And thirdly, we have shown that PARP inhibitors are similar to each other in terms of progression-free and overall survival. And for our daily practice, we can take home that platinum is a valid treatment option for this molecularly selected subgroup of patients. However, interventional and even at the first step prospective trials would be needed to compare these agents with one another. and the optimal sequencing of them is still unknown. There may be possible cross resistance between these agents, so crossover trials would be able to answer this question. So this manuscript, I just checked it, and it's under this. So we have had a major revision in the second best urological journal, and it's now under decision, so fingers crossed. And we had some additional activities in the last year. High projects, we won first and second places in international conferences, and I got a UNKP, a New National Excellence Program scholarship from the Ministry of Innovation and Technology from Hungary, and I would like to thank you for your attention.
Thank you very much for your nice presentation.
How would you design this cross-sectional study, which you have mentioned as a further implication of your results?
Yeah, I think it should be, I think someone has done it, similar, something like that before, but it was not a prospective, they just assessed it retrospectively. So in our second meta-analysis, we were collecting data about sequencing of the agents, but there are just there are maximum case series assessing these questions. But I think the inclusion criteria would be definitely, so there would be only be enrolled molecularly selected, so BRCA positive patients, and then one arm would receive platinum, the other arm would receive PARP inhibitor. It would be really challenging to design it because I think we are not there yet in the evidence in the literature that we would have enough data to design this analysis, because we don't even have prospective data for platinum in this molecularly selected patient group. There are 3 ongoing trials which are going to end next year. So, but these will be the 2 arms, and upon the progression, which I would choose radiological progression. This is the most widely accepted progression, and in the daily practice, the treatment decisions are not based only on the PSA level, so PSA progression, rather than clinical or radiological progression. I think that would be the indication for the for treatment switching, and then we would compare the PFS1s, PFS2s, and then the overall survival of these agents. I would definitely include biomarker and biobank studies, because there is data from the literature that there can be even a reversion mutation of the BRCA mutation after PARP inhibitor treatment. So when a patient reaches the state of PARP inhibitor resistance, and then you compare the tumor tissue, then sometimes it's just it was just a case. There is just one case in the literature, but it has been shown that even these acquired resistance to PARP inhibitors can be used after the or during the therapy.
I spotted something on first project question 2 slides, result slides, where you had those Kaplan-Meier curves that you pulled. Can you please go back there? Maybe I was wrong, so...
I think you were right. I spotted it yesterday, and but I was not able to correct it. So I think it's vice versa, so abiraterum versus... Oh, no?
No.
Then I spotted something else.
Yeah.
Yeah.
So here, what is really staggering to me is that you have ANALA 2018 and ANALA 2021, both plummeting to 0 probability of progression-free survival at quite different times, and it's the same patient or the same author, and then you have another one which is not. So it seems like they're behaving completely different, these 3 Kaplan-Meier curves, and 2 are kind of related because they're from the same author. So I presume it's the same population that they are sampling.
It's almost the same population, where in case of ANALA, the treatment lines were restricted to the first treatment line, while in the case of Torquato, it will allow the second line treatments as well. So
Okay.
question, but there is no overlap between these.
No. That's not what I was just wondering why they are behaving, but that kind of answers it. It seems that these, at least the left two and the right one, is behaving completely different in terms of survival. But now I understand that it's a different set of patients. And you kept mentioning that you were using estimated individual patient data. What's the benefit of that?
The benefit is that if you don't have data, then you can estimate it. So we ask for the real individual patient data of every author, especially for the first project, which the data was really limited. You could see it, that we could reach only 100 patient number, which is compared to the administration of these agents, it's really low. But in this, it shows the importance of this study that and the really up-to-dateness of the study, that we don't really have much information in this molecularly selected subgroup. So we had really a lot of problem with the methodology of the first study, and as we did not have the real individual patient data, we read it from the Kaplan-Meier curves and estimated it. So it's not the best, but it works when you still want to somehow address the question that you asked. So
I'm not going to ask anything about your projects, because the first one was accepted by a D1 journal, and so am I, to ask anything in that. I hate these PhD defenses when people ask questions from the poor candidates when they publish basically nothing in the topic. So anyway, as an anesthesiologist and intensivist, I'm interested, where is the role of surgery in your story? Because you only mentioned drugs so far. So what is your view on the role of surgery in that patient population? And would your results had any effect on the surgery of prostate cancer, which is highly important?
Our patient population was about really the most advanced that you could get. It's metastatic and castration-resistant at the same time. So this is the worst that you can get. And in the treatment landscape of prostate cancer, this is the end phase. So, but we still have 7 agents to work with, and surgery has no role in this metastate, in this state of cancer. The surgery of BRCA positive, so germline mutation carriers, because there are 2 kinds of mutations that can be the germline or the somatic mutation of these BRCA genes, and the most important, the surgery could be the most important for the germline carriers of the mutation. I'm telling you this because generally when a patient is diagnosed with organ-confined disease, so with localized prostate cancer, with no metastasis, which is hormone sensitive, we can choose between surgery or irradiation or even active surveillance, but not the BRCA ones. And when a patient has high-risk features of organ-confined disease, like really bad grading, like this Gleason score, really high Gleason score, or if it's a locally advanced disease, so T3 or T4, then there is an indication for germline testing of these patients to identify possible later candidates of these agents. But there is no difference between the surgery for the BRCA patients or the non-BRCA patients, but there is a concept now that, just like in the case of breast cancer, that now we are performing prophylactic mastectomies for germline BRCA carriers, that there was a study, and there are more and more authors who are thinking and writing about performing prophylactic prostatectomies or some kind of local treatment before even the cancer would have been developed for the BRCA2 carrier patients. In my personal opinion, this would lead to a serious over treatment, because the consequences. So just the other day, I had a conversation with someone who needed to have a mastectomy. So in mastectomy, of course, it's bad to have a mastectomy, but in prostate cancer, you are going to be incontinent, impotent, or you may need a urinary diversion if you cannot pee. So the quality of life is really really should be aware of about the quality of life of these patients. So telling someone to do a prophylactic prostatectomy on a healthy patient, I think it's over treatment, and it only elevates the or lowers the quality of life. But there is more and more data that if we know that someone has germline mutation in the BRCA gene, that how should we follow up these patients, because it's obvious that as these prostate cancers are occurring at a younger age, we should do something in an earlier stage. So now we ask every patient for the family history of any type of cancers, and if we detect something extraordinary like pancreatic cancer in the family at a younger age, or other colorectal gastrointestinal cancers, or breast cancer at a young age, or multiple prostate cancers in the family, then the clinician should be aware that this patient might have some founder mutation, from germline mutation from the family, and this patient should undergo germline testing up to genetic consultation, and should undergo more thorough follow-up and prostate cancer screening based on PSA and MRI. And we know that if we have found a BRCA positive cancer, but among prostate cancers it's not that malign, so with a lower grade, then the upstaging of the disease during active surveillance occurs just more frequently compared to the wild type one. So we really have to take care about this group of patients, but there is no difference in surgeries.
If you know that somebody is BRCA positive as a man, is there some option to make care to see how it's developed?
Or you mean to follow up, or to
follow up? Yes, he's BRCA positive, but he doesn't have any prostate cancer in that time. How do you follow him? Mm-hmm. Is there some evidence in the literature?
Yeah, we got a really low-level evidence, and especially from Israel, where the Ashkenazi Jewish founder mutation of mainly the BRCA1 gene. So it's really common in that population. That's why the majority of the data is coming from there. And there is an ongoing prospective registry of these patients. Every patient, they are looking for the best diagnostic sequencing, and every patient gets PSA and a prostate MRI and rectal digital examination, and they are assessing different cutoffs of PSA level and different cutoffs for MRI score for the indication of prostate biopsies, and then they try to calculate with decision curve analysis that which method is the best. But currently it seems that screening should be started from the age of 40. So generally, men should undergo prostate cancer screening from the age of 50. But for these patients, screening should start earlier, from the age of 40. And these patients should undergo PSA examination. And when it's above 1.5 or 2 nanogram per milliliters, the normal is, or let's see, the normal is around 3 or 4. Then these patients should undergo MRI, and if the MRI is positive, then there is an indication for biopsy. That seems to be the best strategy for them. So PSA if it's positive, MRI if it's positive, then biopsy.
On your first slide, you have a very frightening information about our chances on prostatic carcinoma. Do you have any information about how successful is the Hungarian urological screening in that field?
That's a good question. First of all, we don't have screening. And secondly, it's not that a big problem, because in Hungary it is, but even both the European and both the NCCN guidelines do not recommend, or neither these guidelines recommend systematic prostate cancer screening in the general population, because the big screening projects I could talk minutes about this because this is my other project, not in this, but in these these recommendations are based on older screening trials, which was based only on PSA. And there are many currently ongoing trials which are based on PSA and prostate MRI, which gives a really new horizon in the disease management and detection. So, so I think there is a place for prostate cancer screening for organized nationwide screening programs, but we should not use PSA only, but include other parameters with which we can narrow down those patients who should be biopsied or not. And again, the other thing is that in Hungary, not even the GP is allowed or reimbursed after sending the patient for a PSA examination. That's the biggest problem.